Hello, welcome back.
Hi, hi.
All right, so for the sake of time, I'm gonna start um, mechanical power. So this talk we probably would take like good 3, 4 hours. So I'm gonna try to cut it into 30 minutes. Supposed to be like the hottest thing in mechanical ventilation over the last couple of years. Um, So basically, what I'm going to try to explain is what is energy, what is power, what is mechanical power, how are we going to calculate it? Is it important? Is there any relation to ventilator-induced lung injury? How about transpulmonary mechanical power? What are the role of adaptive modes? And some questions to be yet answered. All right, it all stems from the equation of motion. I'm not going to stop here too much, but basically, the ventilator to put the air in our lungs, need to overcome elastance, resistance, and auto peak. And of course, it all comes to elastance. Pressure, I mean, is elastance times volume, resistance times flow, and peak. Again, I'm going to skip this. Ventilator-induced lung injury, it happens every single day. It worsens mortality. It prolongs stay in the ventilator. Do we diagnose it? Of course we don't. You know why we can't diagnose it? It's because we don't have a diagnostic tool. Um, we always think once the patient was doing okay and start getting worse, a little bit hypoxic, we're like, oh, it's pneumonia. We get x-rays getting worse, FI2 is getting high, it's pneumonia, we start the antibiotics. Do we change our ventilator strategies to see why? No, we did this to the patient practically. We should call it clinician-induced lung injury. Um, why? Because it's, tidal volume too high. Again, I'm not a proponent of that low tidal volume strategies, but anyway, so that's strain, high pressures, flow rates, respiratory rates. I'm going to concentrate on all this talk. You might heard it from previous speakers. When it comes to boil down to it, respiratory rate is the most important thing. And when I talk about the equations for mechanical power, you find the most important one is respiratory rate. So in that ARMA trial, ventilate everybody with 6 milliliter per kg, then increase the respiratory rate to 30, 35 for their hypercapnia. I mean, I probably shouldn't say the word screwed, but we screwed up. So anyway, so what is mechanical power? Mechanical power is basically the energy delivered from the ventilator to the patient's lung, and it incorporates all the components that cause lung injury: tidal volume, flow, inspiratory pressure, inspiratory time, the PEEP, and the respiratory rate. So what is energy? I know none of us are physicists or mathematicians, but basically energy is equal work, and it's in joules. Work, if you remember from high school, is force times displacement. So when it comes to our ventilators, force is the pressure, how much pressure the ventilator is putting in our lungs, and the displacement is the volume. So it's basically pressure times volume. So what is power that everybody talks about? Power is basically work over time. So that's why it's joule per minute. And if you look at most of the equations in red here, it's basically 0.098. It's just a mathematical conversion, respiratory rate, pressure times tidal volume. So it's pressure times tidal volume. And then, oh, the battery is there. Okay. Then this is the most important slide. Some of you might be young, you wouldn't remember Rocky. But that's my analogy for the whole mechanical power thing. How many times you can get punched if you're in a boxing match? If you get punched 5, per round, you might survive a couple, 6, 7, 8 rounds. If you get punched 35 times, you're not going to survive 1 round. Okay? How strong you get punched? If I'm doing this to you, like, okay, you'll survive. If it's Mike Tyson and he's like hitting you like maybe a couple of punches, so that's the pressure. And how many times your head will, let me see if I can start that. Shane, need help. Oh, here, sorry. So that's Rocky getting, berated by the Russian Drago. So you can see how much he gets. So each punch, that's the respiratory rate. And I think that hopefully that convinced you to do that, what the ventilator is doing to our lungs. The high pressure, the high volume, the high respiratory rate, that's what is injuring our lungs. Okay, the factors, we talked about it, the patient muscle effort, tidal volume, flow, pressure, PEEP, all these things. And now we have some fancy names for kinds of lung injury and traumas. We all know the barotrauma and the volutrauma, the old ones. Now we have atelectotrauma, ergotrauma, rheotrauma, biotrauma. We're trying to be cool, but at the end of the day, we can't diagnose any of them. So again, how are we going to calculate this? Basically, it's the area under the pressure volume curve. So if you look on the left side here, I lost my... Okay, so this is a volume controlled square wave form on the left, and this is pressure controlled. Area under the curve. So the energy or the joules every breath is this area under the curve. And to make it more, and this is in pressure control, and you can see if it's even the same tidal volume, same pressure, pressure control gives you a little bit higher energy or mechanical power. Saying this, I never use volume control, so I always use pressure control. And you will ask me, or if you're saying it gives higher mechanical power, why are you using it? I don't have an answer, but I have other answers. Anyway, so we can divide the components of work, make it more complicated. Not only we're dealing with mechanical power. No, you can divide this into resistive power, this part in the green here, which is basically the amount of energy that the ventilator has to overcome resistance. So the question, is that important? Does that injure the lung? Well, no, this is gets converted into heat because energy cannot be created or lost, whatever. Like I can't remember what Newton says. But basically it gets dissipated, does not reach our alveoli. So it doesn't hurt our lung problem. Okay, so what's more important? It's that elastic component. Again, the pressure to overcome elastance. And then if you look at it, and that becomes part of the controversies, there is static, elastic static, which is basically the PEEP. So this pressure or this energy is stored in our lungs. It does not change. So the question becomes, when we calculate total mechanical power, we're including the PEEP. Is it important? A lot of people would argue that it probably isn't important, and the most important part is that elastic dynamic, the tidal work. So again, if you look here, resistive work, elastic work, PEEP work, inspiratory work, tidal work. So it gets a little bit complicated. I'm not gonna spend so much time. Same curve, but maybe a little bit better. Resistive tidal, resistive elastic, which is static tidal, and PEEP, and this is spontaneous person. There's no resistance because he's not intubated. All right, how are we going to calculate it? If you look, since people think actually the part of mechanical power is new, it really isn't new. It's actually been talked about it from the 50s. There's an article by Dr. Otis, which good luck reading it. I tried to read it. I couldn't understand. I quit in the middle of, after spending a week. You can't understand it. Damn smart people. But anyway, so there is now many ways. The ideal or the gold standard of calculating mechanical power, as I told you, we have to calculate that area under the curve. And again, if you're not a mathematician, we're all clinicians, you are not going to be able to do it. Good luck. So they came up with many different equations, basically to try to get surrogate for that mechanical power. So God rest his soul in peace, Dr. Gattinoni, he started that whole thing with the volume control, and he had his equations, then the pressure control, and they made simplified equations and complicated equations. And to be honest with you, if you're going to use those at the bedside, even simplified, yeah, you need a calculator, and you're going to spend a couple of minutes. So despite it's important, it's really hard to do. But again, if you think about it, it's change of volume, change of pressure, change of respiratory rate, multiplied by a conversion factor. We'll talk about the equations a little bit later. This is just, again, like a quick, if you want to calculate it in the volume control, in the constant flow, so minute ventilation multiplied by peak plus PEEP plus inspiratory flow over 6 over 20. If I give you numbers right now and give you 30 seconds, nobody will be able to. And pressure control, respiratory rate times tidal volume, delta pressure plus PEEP, and anyway. So some genius people came up with an equation and published it. This is also a bad joke. We called it the M&M equation. I thought it would be actually a pretty catchy name, M&M, like the candy or the. But now, like thinking about it, it actually sounds like pretty stupid. But anyway, so what is M&M? M small is the mean airway pressure, and the big M is the minute ventilation. So I said, like, let's simplify it. The ventilator tells you all the time what's your minute ventilation, and it tells you all the time what's your mean airway pressure. So they're obviously just calculate, multiply them together, and we're gonna get an equation. So actually, and Shane here, he's a smart guy, very smart guy. He is a mathematics engineer and physician and everything. Help me with this. And so we got actually surrogates. If you multiply, say you have a minute ventilation of 10, mean airway pressure of 15, that's 150. We did all the statistics and regression analysis. We came, if you're in pressure control, that's the equation, 0.15 plus 0 multiplied by the M&M plus 3.79, boom, that's your mechanical power. Problem is this, when I try to use this on the patient, I can't even remember those numbers too. You think that I should. So for volume control, it's that equation below. And that's basically the study. It showed great correlation with not with any of the equations that people made. Actually, we compared this equation to the gold standard of measuring mechanical power, which is the pressure volume curve, the area under the curve. And we tried to make it simplified here. So it's like, if your M&M is like 285, your mechanical power is 15. If you're 120 and blah, 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 blah. Even this people can't remember. Anyway, so that was in a static condition. If the patient's paralyzed, doesn't have any effort or something. The trouble is we don't paralyze everybody. So what is the mechanical power in somebody who has spontaneous triggering, spontaneous breathing? And you know what? Nobody knows. So what are we going to do? So we made another part 2 for the M&M. You know how like in Hollywood, they always do sequel and sequel get worse than the first one. So I think that was it. So basically we tried the same kind of like, same study, but in people with spontaneous breathing effort. And we came up again, we went sophisticated this time because instead of calculating only the mechanical power, we even divided the power into what is the power that the ventilator is giving, what is the patient own power, because the patient is doing some power, is working, and what is the total power in both the pressure control and in the volume control. And we came up again with the same, with equations. Of course, there are different equations. So if you're going to use this M&M, you have to know the patient passive or active. Again, like the same, stuff that scatter plot. So what we did, if you go to the Society of Mechanical Ventilation, then / calculator on the top here, we put almost all of the equations that used to be calculated the mechanical power. Gattinoni, I forgot all the other name, Bark, or whatever his name. There's a lot of equations, not only mechanical power, you'll find oxygenation index, ROX index, whatever. So please feel free. I didn't put the new study yet. To be honest with you, none of us were going to get the calculator and keep pausing and what is the pressure. We just need the ventilator. Why does the ventilator tell us? Actually, Steve in his equations in his lecture said the 7200 had, power, right? And that was back in the 70s. When I was a resident, I worked on that ventilator. It was like a cashier machine, if that machine from the 70s could tell us, why don't we have our fancy ventilators like they have it? So I'll tell you a secret here that nobody knows. I told Steve from Zoll, I have the ventilator that actually calculates the numbers for you. Okay? You're not gonna, it's not on the market. It's not, apparently you have to get FDA approval for everything you do these days. I don't know, but anyway, it's not commercially available, but I can guarantee you in the next couple of years, each ventilator would have it. And that's what we need. I want the ventilator to tell me the number. Anyway, so we talked about like the mechanical power and could be injurious to the lung. We talked about esophageal balloons, although we didn't really speak much about them. Having the esophageal balloon basically enables you to calculate the transpulmonary pressure. Transpulmonary pressures are basically airway pressures minus esophageal pressures equal the transpulmonary pressure. So by looking at the transpulmonary pressure, this is the pressure that the lung only is exposed to pressure. The people talk about the plateau and oh, plateau 30 or 40 or 50. Oh my gosh, we're killing the patients. I don't care. It is what happens to the lung because somebody, all these obese people or like have bad chest wall compliance, maybe ascites, maybe pregnancy, you name it. You know, they might need very high plateau pressures. What is the lung seeing? This is the transpulmonary pressure. So we don't put the esophageal balloon in every single patient, but the ones that really I think they need it and they're complicated and not easy, you know, we always do it. Okay. So remember I told you that mechanical power is the area under the curve. So if you look here, this is the whole respiratory system. So this is airway pressure versus tidal volume. But if you have the esophageal balloon, you can also plot the transpulmonary pressure versus the same tidal volume. So you can see that the lung itself, that's the transpulmonary mechanical power, will be much less than whatever you're calculating. What we calculate is just the total respiratory system. Make sense? Okay. Then another genius people. That is another joke and nobody laughed. But anyway, that was me and my friend from Brazil. We decided like, okay, how about the tidal volume? We're using the whole tidal volume. First of all, that tidal volume, there is almost 30, 40, 50% of it is called dead space because it's lost, our alveoli doesn't see it. So we decided to use the volumetric capnometry and use that volume, the alveolar tidal volume. What is the alveoli really seeing? That, like if you put a patient 500 tidal volume, okay, well, your alveoli is seeing only 200, 250. That is the number that we're going to use for our mechanical power. And we'll use the esophageal balloon to calculate basically now alveolar. So we came up, and surprisingly, nobody talks about this. We talk about chest wall mechanics, compliance resistance, lung compliance resistance. Nobody ever came with alveolar compliance. So we were mathematically, we were able to get alveolar compliance, alveolar flow, alveolar resistance. We don't think about that. We think that our alveoli does not have any resistance. Believe it or not, according to the math, it does. And we came up with the transalveolar mechanical power. We used the same equation, but of the transpulmonary mechanical power, but instead of using regular tidal volume, we used the alveolar tidal volume and the alveolar elastance. Anyway, you're welcome to read it. It's not that. Okay, so we calculated the mechanical power and everything. Now what? Say your mechanical power is 20, and most of the journals say, like, or the studies or whatever say, oh, 15, 17, above that, you're going to injure the lung. Okay, if you're 17 and you're one of those, that's probably not going to injure you. You know, if we're one of those, we're talking about mammalians, you know, it might be too much. But if you put that 17 in that small mammal there, it will be too much. So the mechanical power alone might not be enough. I think we should index it to whatever you want, either the ideal body weight, the compliance, the functional residual capacity, total lung volume. There's some studies, and again, those are the unknowns in mechanical power. Since I said I'm going to concentrate on resistance, this is also a study by Dr. Gattinoni. Again, God bless his soul. He's one of my heroes in mechanical ventilation. He just died earlier this year. Anyway, so this is the relation between the elastance and the resistance and mechanical power. So the more you're worsening the elastance, the more the mechanical power will increase, basically more than the resistance. And again, one of the questions is we don't know is even resistance is important even? I really don't think so. Okay, how about the relation of mechanical power to all? If you look at the left one, you would think, oh, that's the one that increases mechanical power. But guess what that is? That's a combination of driving pressure and tidal volume and the inspiratory flow. So the three of those on the left ones here, increase the mechanical power that much. Guess what? Respiratory rate alone, almost close to it. And then the PEEP is like here. So I put that graph is just to show you that increasing the respiratory rate will increase the mechanical power. So really, it pains me sometimes when I go see, it's like, okay, we're keeping the tidal volume low, we're keeping the driving pressure low, but the patient is breathing 35, or we set it at 30, 35. Every time you increase that respiratory rate, you are increasing the mechanical power. You're getting punched one more time. So, okay, how about adaptive modes? Adaptive modes we have in the US is the ASV and the AVM that hopefully we're going to do a workshop on it. I'm not going to dwell through it, but just this is the same patient. He was here in pressure control, and we calculate the power 12.96. It's actually not me, that's Arnaud. And then when you switch to ASV or IntelliVent, it came down, it dropped by like almost 1 joule per minute. Good. This has come from a study that actually we published in real patients. Basically, and this shows, I like it because it shows a transition. So here, when the patient was on pressure control, you can see like how high it is, the flow was this much, the volume is this much. And once we switch into like the adaptive mode, the AVM, you can see like this big difference. The pressure dropped, the volume dropped, the flow dropped, the respiratory rate dropped, and granted we could, we put them on 100%. If I put them on 50, it would be less. If I put them on 150%, it could be high. But you can see that the ventilator actually is smarter than us. The ventilator side is like, oh my God, you're using so much pressure. You're using so much respiratory rate. So they're doing it for us. Okay, so quick, another one. This is also a study that we did, but a simulator study to compare pressure control to volume control to AVM in normal lung with different tidal percent minute ventilations. And basically, I just want to show you the adaptive mode is always on the bottom. So it gives you much less mechanical power, much less pressure, much less tidal volume. Then we got sophisticated for the next one. We said, let's do one for ARDS. Again, these are all simulated, one with the ASL machine. And then we went again we're going to use different minute ventilations here. 7 liters, which is 100%, 10.5 liters, 150, and 200%. And we made mild ARDS, moderate ARDS, severe ARDS. And you can see again in all of them, the adaptive mode gave you the least tidal volume, pressure, mechanical power. So the conclusion really is it is smarter than us. Then we did this in 20-something patients, and we published it also where we put our patients on pressure control, and then we had an IRB and everything. It wasn't randomized, so it's only 22 patients. Then we crossed them to AVM, almost with the same minute ventilation. So if they were getting, say, 10 liters on the regular pressure control, we adjusted the percentage of the minute ventilation to be almost the same. They were not all ARDS, so it was whatever we can. Then we calculated the difference. So this time AVM is on the orange, it was blue before. Pressure control, the tidal work was higher, resistive work was higher on pressure control. So basically, again, the same conclusion, it improved everything. Again, this is the same thing, mechanical power, total power, it reduced everything. Again, same conclusion. I'm going to skip with this because we don't know actually what part of the mechanical power that injures the lung. Is it, tidal volume, respiratory rate, pressure, whatever. This is Gattinoni did that study and it's like, oh, it looks like whatever increased mechanical power, would worsen the lung. And he came with that 12 joules per minute. And in reality, if you put any patient who has respiratory failure, to get that 12 is pretty challenging when you do the calculation. 12 is actually pretty good. This is another study, I like it because it's about the transpulmonary mechanical power that we talked about. And the more the transpulmonary mechanical power gets worse, you can see here, not too bad, get worse at at 2025. So mechanical power and mortality, again, I'm not going to go through all the studies because I'm pretty sure we are behind. The gist of them all is there is a big relationship with mechanical power, worsening high mechanical power and mortality. This study was like a prospective study with a lot of patients, and they came up with the number 17. You know, Gattinoni was 12, this came up with 17. This is another study, like meta-analysis of two studies. This is a scary one, and it just came like a couple of months ago. It shows like when mechanical power exceeds 18, every hour increase the risk of ICU deaths by 0.1%. Every hour. And I can tell you, like, when I try to sometimes to calculate our mechanical power, because it's like, whoa, the patient is breathing 30, whoa, their volume, their pressure is blah, blah. Sometimes I get 25, 26, scary numbers. Every hour you were increasing the risk of death. So imagine if we left them there for 4 or 5 days. You know. Okay, some partially answered or unanswered questions. We know now that mechanical power is related to ventilator-induced lung injury, related to mortality. Which lung can be, you can hit worse? Is it the sick lung or the normal lung? You would think that that's an answer question. People argue about that. Is the respiratory or the transpulmonary mechanical power we should target? It definitely should be the transpulmonary. Problem is we need to esophageal balloon in those people, and we don't use the esophageal balloon enough at all. How about the alveolar mechanical power? I was hoping that somebody would follow up on that study that we did. Nobody, no takers yet. What component of the power is important? We talked about, but again, what I think, it's not the resistive, it's not the PEEP, it's that elastic dynamic one. Should we target a certain number? Like, oh, it's like, oh, should we, okay, it's less than 17, we're good. No, get the lowest you get is the best, the better. What's the best way? We know that the best way is calculating the area under the curve, passive or active patients, automatic measurements. And I am actually going to skip those. Those are just some examples to show you, like, hey, the mechanical power, you know, this patient with the same, you know, on volume control and pressure control, both have the same mechanical power. Are they going to have like different mortality? I don't know. This is a patient who was passive and active. So this guy is breathing and this guy is not breathing, and the mechanical power is the same. Is there any difference in mortality? Again, nobody looked at this. This is also simulated work that we did. This is a patient with pressure control. So if he is passive, patient is not doing anything, 14.45, make him breathe. It goes up to like higher. I can't even see what the number is, but it goes higher. If the patient is passive in volume control, it's this. When actually the patient start breathing volume control, because now he helps the ventilator, he reduces the pressure. Believe it or not, the mechanical power becomes less. Still wouldn't convince me to use volume control. Power compliance index, transpulmonary. So conclusion, what are we going to do after all this? Okay, great. There is mechanical power. Great. It worsens mortality and, you know, and lung injury. What are we going to do? I would tell you, just tolerate the lowest. I know we're always suckers for tidal volume, and now we're suckers for the driving pressure. Please, let us be suckers for the respiratory rate. I think it's much more important than the tidal volume and the respiratory rate and the driving pressure. Okay, we'll put the PEEP, adequate PEEP. Well, good luck with that. Like you hear about the optimal PEEP, and somebody asked, what is the optimal PEEP? And there is nothing called optimal PEEP. Nobody knows. Try to put a esophageal balloon and try to calculate the transpulmonary pressure. Prone position might help. Adequate sedation, people like, you know, like this guy. So this person is esophageal pressure, and you can see it goes from like almost 15 to -5. And sometimes we're okay with that. You know why? Because most of the time we don't have that esophageal pressure. So we're looking at the airway pressure. Okay, things don't look too bad, right? Then you put the esophageal pressure, and like, so you're looking at this side of the patient. You turn from inside, and it's like, oh my God, this is not acceptable. The guy is working with like -25, pulling 25 centimeter. That will injure the lung. And you're not going to see that without an esophageal balloon. All right, with that, I'm going to stop. And if you have questions, keep it to yourself. Any questions, Benjamin? Sorry. No questions. All right. Thank you.